Picture this. A 35-year-old patient is, say, 3 days post-op for a routine laparoscopic hernia repair.
Okay, pretty standard.
Right. They're recovering on the ward when suddenly their blood pressure just crashes. I mean, their abdomen becomes grossly distended, and pumping them full of IV normal saline does, well, absolutely nothing to stabilize their hemodynamics.
Oh, wow. That is terrifying.
It is. They are in profound septic shock, and the culprit is entirely invisible to the naked eye. So welcome to the diagnostic black box of the acute abdomen.
It really is the ultimate high-wire act in medicine. When a patient presents with an acute surgical crisis like that, you are no longer relying on, pristine textbook scenarios.
Yeah, the textbook goes right out the window.
Exactly. You're operating on incomplete information, and the physical exam just has to guide decisions that carry immediate life or death consequences.
Which is exactly why we are jumping into a legendary foundational text today. We're doing a deep dive into NMS Surgery, 6th edition, by Drs. Bruce Jarrell and Stephen Kavic.
It's a fantastic resource.
It really is. So for those of you navigating clinical rotations, or maybe you're prepping for surgical boards, or you're just hungry for an advanced masterclass in clinical intuition, our mission today is to distill the highest yield clinical pearls from this material.
The book calls them quick cuts and chapter cuts and caveats.
Right. I love that term. We are bypassing the fluff and focusing directly on the surgical decision-making process. The goal here is to build your clinical intuition so you know not just what is happening, but exactly why.
And that journey really always begins before the scalpel is even picked up. When you are looking at a patient with an acute abdomen, the very first filter for your differential diagnosis just has to be location.
Location.
Right. Anatomy dictates the clinical approach. So the right upper quadrant points you to the biliary tree or the liver. The left lower quadrant brings diverticulitis to the top of the list. But as any seasoned diagnostician knows, anatomy can occasionally lie to you.
Yeah, which brings us to appendicitis, famously known as the Great Masquerader. We learn early on that the classic presentation is this vague periumbilical pain that eventually migrates and localizes to the right lower quadrant.
Yes, the classic migration.
But the appendix is notorious for assuming completely different anatomical positions, isn't it?
It is, yeah. The appendix can be retrosical, meaning it's tucked up behind the colon, or it can hang deep down into the pelvis. Because of those anatomical variations, the localized pain can mimic entirely different organ systems.
Oh, interesting. Give me an example.
Well, a pelvic appendix resting against the bladder might present with dysuria and frequency, so it's masquerading as a severe UTI.
Wait, really? A UTI?
Yeah. Or in female patients, it can be nearly indistinguishable from pelvic inflammatory disease or a ruptured ovarian cyst. You have to rely on the underlying physiology, not just the ZIP code of the pain.
That is wild. And we've seen another really unique presentation in pediatric patients when we look at mechanical obstructions, specifically intussusception. We know this is where the proximal segment of the bowel basically telescopes into the distal segment. But the clinical hallmark isn't just pain. It's the passage of current jelly stools. I've always wondered why that specific presentation.
It all comes down to vascular compromise. When the bowel telescopes into itself, it drags its mesentery along with it. The venous outflow gets pinched off first because veins have thinner walls and lower pressure.
Right. That makes sense physically.
But the thicker-walled arteries, they keep pumping blood into that trapped segment of bowel. So you get massive venous engorgement, mucosal edema, and eventually ischemia.
So the tissue is literally dying.
Exactly.
Yeah.
The current jelly is actually a sloughing mix of mucus and ischemic blood from that dying mucosal layer.
Man, so you have this incredibly volatile landscape. The appendix is hiding, the bowel is telescoping and ischemic. As the diagnostician, you're gathering these clues, but there has to be a definitive threshold where observation ends and surgical intervention becomes mandatory.
Oh, absolutely. The undeniable red flag is a rigid abdomen. If you palpate the patient and the abdominal wall is like board-like and unyielding, you are looking at diffuse peritonitis. And this is a surgical emergency.
Okay, let's unpack that. Let's drill into the physiology of that rigidity, because the body is effectively turning the abdominal wall into a physical shield, right?
It really is. The peritoneum is the highly sensitive serosal membrane lining the cavity. When a hollow viscus perforates, whether it's a burst appendix or a perforated duodenal ulcer, highly caustic substances like gastric acid, bile, or fecal bacteria just flood that sterile space.
Which sounds agonizing.
It's catastrophic. The body's somatic nervous system responds to that chemical and bacterial irritation by triggering involuntary reflex spasms in the rectus abdominis and oblique muscles.
So they literally can't relax their stomach even if you ask them to.
Nope. They cannot relax them. It is a pure autonomic defense mechanism to prevent movement that would spread the contamination further.
Wow. Well, that mechanical failure of a hollow viscus perfectly introduces our next major surgical arena, because we're moving from the inflammatory crises of the acute abdomen to cure structural breakdowns. I'm talking hernias and bowel obstructions.
Yes, the mechanical blowouts of the abdominal wall and the GI tract. And, mastering the anatomy here is completely non-negotiable.
Totally. So let's start with the inguinal canal. The critical distinction here is between direct and indirect inguinal hernias. The inferior epigastric vessels serve as the anatomical dividing line, right?
Correct. Direct hernias push medial to those vessels, while indirect hernias push lateral to them.
But the indirect hernias are fundamentally a developmental issue, aren't they?
Yes, they are. An indirect hernia is driven by a patent processus vaginalis. So during fetal development, this outpouching of the peritoneum travels down through the inguinal canal to allow the testes to descend into the scrotum. And it is supposed to obliterate and close off before birth. But when it fails to close, when it remains patent, it leaves a preformed anatomical highway. So abdominal contents, like a loop of small bowel, can slide straight down into the inguinal canal or scrotum.
Which totally explains the distinct epidemiology we see in pediatric patients. The source points out that pediatric inguinal hernias are overwhelmingly indirect, with a male-to-female ratio of 6:1 simply because of that testicular descent pathway.
Exactly.
And interestingly, 60% are right-sided, which is likely because the right testicle typically descends later than the left, leaving that side pattern longer. But unlike pediatric umbilical hernias, these don't close spontaneously as the child grows, do they?
No, they do not. Because it's a persistent anatomical sac, not just a fascial weakness, it requires definitive surgical ligation. If you leave it alone, you're inviting a high risk of incarceration and strangulation of the bowel.
Right, which is basically a ticking time bomb. Now, we usually associate hernias with these natural transition zones, like the groin or the umbilicus, but there's also the Spigelian hernia, and that happens in what seems like a completely random location on the anterior abdominal wall.
It seems random, yeah, until you actually look at the fascial architecture. A Spigelian hernia protrudes through the semilunar line, which is the lateral border of the rectus abdominis muscle.
Okay.
But it specifically occurs near the semicircular line of Douglas, just below the umbilicus. This is the exact point where the posterior rectus sheath abruptly ends.
So it's basically an anatomical weak spot.
Exactly. Below this line, all the aponeurotic layers pass anterior to the rectus muscle, leaving only the thin transversalis fascia behind it. It's an inherent evolutionary weak spot in our abdominal armor.
Wow. And fixing these structural weak spots has evolved dramatically. You have the classic open Bassini repair, which involves suturing the transversalis fascia and conjoint tendon down to the poupart ligament to recreate the inguinal floor.
A classic for a reason.
Right. But then you have incisional hernias, which are essentially iatrogenic failures, meaning we caused them.
Yeah, incisional hernias occur at the site of a previous laparotomy scar. The native fascia has been cut, and the resulting scar tissue is mechanically inferior to normal aponeurosis.
So you can't just sew it back together.
Rarely. Primary tissue approximation is rarely enough because the tension will just tear it open again. You almost always have to deploy a prosthetic mesh to bridge the defect and offload the pension across a wider surface area.
And this creates such a fascinating paradox. We operate to fix a hernia, but that very operation creates scar tissue. And inside the peritoneal cavity, that scar tissue manifests as adhesions, which are the leading cause of small bowel obstructions.
It's a vicious cycle.
It really is. So you have a patient who comes in with an SBO, a small bowel obstruction. They're completely blocked up. The instinct is to cut them open and free the bowel. But the standard of care for a stable patient without signs of ischemia is conservative management, right? Like NG tube decompression, IV fluids, and just waiting for 1 to 2 days.
That's right.
But wait, isn't a blockage a ticking time bomb? Why hold off on surgery when there is a literal mechanical block in the plumbing?
Because of the inflammatory cascade. I mean, the moment air touches the peritoneum or a scalpel cuts into it, you trigger fibrin deposition. Fibrinous bands form between loops of bowel as part of the normal healing process.
Oh, I see.
Yeah, so if you take a patient with an adhesive SBO back to the OR, You will spend hours lysing those adhesions, only to guarantee the formation of even denser adhesions during their recovery.
So you're trading today's obstruction for an even worse one next year.
Exactly.
Hmm.
If the patient is hemodynamically stable, lacks a fever, and shows no leukocytosis or lactic acidosis, meaning the bowel has adequate perfusion and isn't strangulated, you give the bowel time to decompress.
And it just fixes itself.
Often, yeah.
Yeah.
The edema subsides, the kink often straightens out, and you spare the patient another laparotomy. The exception, of course, is a closed-loop obstruction or any sign of clinical deterioration. In those cases, you must operate immediately before the bowel infarcts.
Got it. Which brings us precisely to the innovations designed to avoid those massive open laparotomies and the resulting adhesions in the first place, which is minimal access surgery.
Yeah.
Laparoscopy fundamentally shifted the paradigm for procedures like ventral hernia repairs and appendectomies.
It really did. It minimizes tissue trauma, accelerates recovery, and drastically reduces those massive incisional hernia rates we just discussed.
However, minimal access does not mean minimal risk. Let's look at a scenario where a patient has an appendiceal abscess. The appendix has ruptured, but the body's omentum and surrounding bowel loops have walled off the perforation into an abscess cavity.
Right.
The standard of care is actually a relative contraindication to immediate laparoscopy. Why is that? Why wouldn't you just go in and get it out?
Because navigating through that dense, acute inflammatory mass with rigid laparoscopic instruments is incredibly dangerous. The inflamed tissues are friable. I mean, they tear so easily.
Oh, so you could accidentally damage something else.
Exactly. If you try to dissect an abscess out acutely, you risk creating an iatrogenic enterotomy in the adjacent healthy cecum or terminal ileum. Instead, you drain the collection percutaneously under CT or ultrasound guidance, administer broad-spectrum IV antibiotics, and allow the acute inflammatory phase to completely cool down.
And then you go back in later.
Yes, you perform an interval appendectomy 6 to 8 weeks later.
Okay, let's talk about the nightmare scenario of an iatrogenic enterotomy, because this circles us right back to the patient we introduced at the top of the deep dive.
Yes.
A 35-year-old, 3 days post-laparoscopic hernia repair, suddenly in hypotensive shock, completely unresponsive to fluid resuscitation. We're looking at an unrecognized bowel injury.
And this is where the limited field of view in laparoscopy is its Achilles heel. A trocar insertion or a thermal injury from an energy device might just graze the bowel wall.
But they don't crash right away.
No, because the necrosis takes a few days to fully break down, which is exactly why they present on post-op day 3. The bowel contents spill into the peritoneal cavity, shifting a clean surgical wound instantly to a contaminated one.
And the hemodynamics of this are absolutely brutal. I mean, they aren't hypotensive just because they're dehydrated.
No, this is distributive shock. The massive intra-abdominal infection triggers a systemic inflammatory response. Inflammatory cytokines cause profound systemic vasodilation and capillary leak.
So the pipes basically lose all their pressure.
Right. The vascular beds lose their tone, and the intravascular fluid third spaces out into the tissues. You can pump liters of normal saline into their veins, but there is no vascular resistance to hold the pressure.
So how do you save them?
The only way to reverse the shock is source control. You need an immediate laparotomy, wash out of the contamination, and resection of the injured bowel segment.
Wow. And the danger of limited visibility extends to the biliary tree during a laparoscopic cholecystectomy as well. If a bile duct leak or transection is recognized postoperatively, the immediate impulse might be to rush them back to the OR and just sew the duct back together.
That's the instinct.
But the protocol dictates strict avoidance of immediate re-exploration. Why can't you just go fix the leak?
Because the biliary tree is highly unforgiving. If a few days have passed, the golden window for primary repair is totally gone. The porta hepatis will be this hyperanemic, inflamed, indistinguishable mess.
So you literally can't see what you're doing.
Precisely. If you go in blindly attempting to find the leak, you are almost guaranteed to devascularize the remaining bile ducts or injure the hepatic artery or portal vein. You must first MAC the injury using ERCP or MRCP, place a drain to control the leak, and plan for a definitive hepaticohegionostomy weeks later once the tissue has stabilized.
That makes total sense. So let's stay with the biliary tree for a minute and explore the pathology that leads to these cholecystectomies in the first place. We know symptomatic cholelithiasis gallstones is the primary driver.
Right, the classic cause.
But if it progresses to acute cholecystitis, the timing of the surgery becomes this massive point of debate. The rule is, operate within 72 hours of symptom onset, or wait 4 to 6 weeks. Why that specific window?
It is all dictated by the histopathology of inflammation. In the first 72 hours, the inflammation is primarily edematous. The fluid-filled tissue planes actually aid in dissection, allowing you to clearly identify the cystic duct and cystic artery.
But after 72 hours, the nature of that inflammation changes.
Yes, the body shifts from acute edema to organization and fibrosis. The tissues become indurated and densely adherent to the surrounding structures.
Which makes it dangerous.
Incredibly dangerous. Dissecting callus triangle during this fibrotic phase dramatically increases the risk of those catastrophic bile duct injuries we just talked about. You must let the fibrotic phase mature and cool off entirely before attempting the resection safely.
Okay, now, most gallbladder issues are mechanical plumbing problems. A stone blocks the cystic duct, causing cholecystitis. Or a stone travels down and blocks the common bile duct, causing choledocholithiasis, which can rapidly back up the pancreatic duct and trigger acute pancreatitis.
Classic plumbing issues.
Exactly. But the truly fascinating clinical entity here is a calculus cholecystitis. This is inflammation and necrosis of the gallbladder without a single stone in sight. How does a gallbladder get inflamed if there's no stone blocking the pipe? That defies the plumbing logic.
It completely strips away the standard plumbing analogy.
Right. I look at the standard biliary tree like household plumbing. But a calculus cholecystitis is more like an industrial chemical processing plant undergoing an emergency shutdown.
That's a great way to put it. This happens in critically ill ICU patients, massive trauma, severe burns, overwhelming sepsis.
So what's actually happening physiologically?
Well, when a patient is in profound physiological shock, the sympathetic nervous system triggers massive splanchnic vasoconstriction. The body aggressively shunts arterial blood away from the GI tract to preserve perfusion to the brain and the heart. So the gallbladder wall becomes severely ischemic.
And because the patient is usually intubated and not receiving enteral nutrition, there is no physiological trigger for the gallbladder to contract.
Exactly. You have a lethal combination. Ischemia compromises the mucosal barrier of the gallbladder. Meanwhile, the stagnant bile inside becomes highly concentrated, turning essentially into a caustic chemical sludge.
Oh, man.
Yeah, the toxic bile begins eroding the ischemic wall from the inside out. There is no physical clog. The organ is simply undergoing necrosis due to shock and stasis.
And diagnosing this has got to be challenging because the patient is often sedated and cannot report right upper quadrant pain.
It is. You rely heavily on imaging, specifically the HI-DES scan. By injecting a radiotracer that is excreted by the liver into the bile, you can visualize the functional patency.
So if the tracer never enters the gallbladder,
then it proves the duct is functionally obstructed by intense inflammation, confirming the diagnosis.
And regarding treatment, these patients are often way too hemodynamically unstable to survive a general anesthetic and a full cholecystectomy, right?
Usually, yes. So the immediate life-saving maneuver is a percutaneous cholecystostomy tube. You place a drain directly through the hepatic bed into the gallbladder to decompress the toxic sludge. It basically temporizes the patient until they recover from their underlying critical illness.
Stabilizing the critically ill patient is really only half the battle, because the other half is navigating the postoperative recovery phase, which is fraught with its own diagnostic challenges.
Absolutely.
For example, when a patient spikes a fever on post-op day 3, the initial workup is guided by a classic mnemonic, the 5 Ws.
Yes, the 5 Ws. Wound, wind, water, walking, and wonder drugs.
So, wind covers atelectasis and pneumonia. Wound is the surgical site infection. Walking targets deep vein thrombosis from immobility. And wonder drugs refers to drug-induced fevers.
Right.
But let's look closely at water, which points to urinary tract issues. Postoperative urinary retention is incredibly common, and it often requires us to look at the underlying urologic anatomy, especially in older male patients.
Yes, anesthesia and narcotic pain medications severely blunt the parasympathetic micturition reflex. In an older male who already has benign prostatic hyperplasia, or BPH, this post-operative autonomic suppression is enough to push them into complete urinary retention.
Because BPH creates a structural bottleneck. I mean, the book notes a firm, non-tender prostate suggests BPH, whereas a nodule would suggest cancer.
Exactly.
The hypertrophied prostate physically pinches the urethra, requiring the bladder detrusor muscle to generate significantly more pressure to overcome the resistance.
And when that detrusor muscle is stunned by anesthesia, you get retention, which requires catheterization and leads to UTIs the water in our fever mnemonic.
So how do you treat the BPH medically in this scenario?
It often involves alpha-1 sympatholytics like tamsulosin. These don't shrink the glandular tissue. They target the smooth muscle receptors at the bladder neck and within the prostate capsule, relaxing the tone and reducing the dynamic resistance so the stunned bladder can successfully empty.
For smaller glands, they might do a transurethral incision or TUI, but open prostatectomy is reserved for glands over 60 grams.
Our
Okay, so once we've navigated the acute recovery, managed the hemodynamics, and cleared the infections, we're left with the final stage of surgical intervention, which is definitive closure.
Right, getting the patient closed up.
For massive abdominal defects, especially after leaving an abdomen open due to contamination or compartment syndrome, plastic surgery utilizes what's known as the reconstructive ladder.
It is a foundational algorithm for wound closure. The ladder dictates a strict hierarchy. You always utilize the simplest, least invasive option that will achieve definitive closure.
So you start at the bottom with secondary intention, basically letting it heal on its own. Then you move to primary closure, then skin grafts, then local tissue rearrangements. And the very top rungs of the ladder involve complex, vascularized tissue transfers like pedicle flaps and ultimately free flaps.
Right. With a free flap, you are taking a composite block of tissue, like an anterolateral thigh flap or a rectus abdominis muscle, completely detaching it from its native blood supply, moving it to the abdominal defect, and performing microvascular anastomoses to hook those tiny vessels into the local recipient vasculature.
It is an absolute marvel of modern surgical capability, but it raises a critical clinical question. If a free flap provides a robust, custom-fitted, highly vascularized closure, why not just jump straight to the top of the ladder for complex wounds? Why bother with the intermediate steps if you know the free flap is the best coverage?
Because the reconstructive ladder is fundamentally an exercise in risk mitigation. A microvascular free flap carries the severe risk of thrombosis at the anastomosis site.
Oh, I see.
Yeah, if a clot forms and blocks the arterial inflow or venous outflow, you get what's called the no-reflow phenomenon. The entire flap will undergo complete ischemic necrosis. You haven't just failed to close the wound, you've created a massive new necrotic burden for the patient, while simultaneously creating a donor site morbidity elsewhere on their body.
The physiological toll of a failure at the top of the ladder is catastrophic.
Precisely. You don't deploy an 8-hour microvascular operation if a simple local advancement flap will provide stable coverage. The latter forces the surgeon to balance anatomical necessity against systemic physiological risk. And a quick note on nerves. If an important nerve is cut during all this, it must be reanastomosed or a nerve graft must be interposed.
Good to know. And really, that balance is the true essence of surgical mastery. From deciphering the erratic presentation of a masquerading appendix to navigating the treacherous hemodynamics of septic shock after an unrecognized laparoscopy injury, and finally respecting the disciplined progression of the reconstructive ladder.
It all requires an understanding of pathophysiology that goes far beyond simply knowing where to place the scalpel. And to ensure that understanding is really locked in for you, consider the clinical vignette we opened with.
Oh yeah, let's review that.
So, you are evaluating a 35-year-old man who is 3 days post-laparoscopic ventral hernia repair. He suddenly develops a distended abdomen, severe pain, and hypotension that does not respond to a liter of normal saline. Based on what we discussed, what surgical complication has likely occurred, and how has his wound classification changed?
Take a second to think about that. You now know that the invisible culprit was an iatrogenic enterotomy, and the lack of fluid response was driven by the massive vasodilation of systemic sepsis, changing it from a clean to a contaminated wound.
Exactly. It's about connecting those microscopic cellular mechanisms to the macroscopic surgical decisions.
We started this discussion talking about the black box of the abdomen. Looking through the lens of these surgical pearls, we arrive at the ultimate, humbling paradox of the operating room. The hallmark of a truly great surgeon isn't just possessing the technical brilliance to know exactly how to cut. It is having the hard-earned clinical wisdom to know exactly when to walk away and when not to cut. Keep diving deep.